we are going to get going. I know we will grow over the course of the next minutes or so. We are incredibly excited to get the community back together and I'm incredibly excited that I saw Linda Hyde enter. We're going to be addressing the domains of digital literacy and digital access over the course of the next months with you all. This is, for a reminder, the open collaborative terminology wing of the terminology division of the Gravity Project. And we are so excited to see new and familiar faces on the call. Next slide, please. Just as a reminder, we thank you for joining. Due to the large number of attendees, participants are muted upon entry. Usually we grow to at least like 80 or so folks. It is our first time meeting in a long time, so the word might need to get out. We ask that you remain muted to avoid background noise. The call is recorded and will be available on the Confluence page following. Everyone's encouraged to actively participate. If you know us from past Gravity calls, we really try to work in any comments from the chat into the conversation. Those comments are really, really very critical when we're doing active conceptual modeling with our terminology development. We really need your feedback when we're presenting concepts that our subject matter experts have crafted, and we're bringing them to you. So if you type something to everyone in the Zoom, I will do my best as the steward of this call to bring those comments into the collective so that we can address them. Next slide, please. This is the important antitrust practices statement. We have the responsibility to comply with federal and state antitrust laws. So you must, anyone speaking or providing written communications shall refrain from any discussion which may provide the basis for an inference. They've agreed to take any action related to prices, services, production, and the allocation of markets, or any other matter having a market effect. And then we can't discuss pricing or other pricing or any term that might affect pricing or fees. So it's important just to ground ourselves in that. There's very little of this kind of conversation on this call because we're talking about concepts and models and meanings, but it's important to make that as a base assumption. Next slide, please. This is the agenda. There's a lot of Sarah here, but I really do hope to leverage some of our subject matter experts, which we will introduce you to today. And we have the honor of our amazing community liaison, Asha, and public health expert. Asha has coordinated with them over the course of the last months, and we had our kickoff for our subject matter experts on Tuesday. You will get to know them well over the course of the next months together, and then we'll close with homework and next steps, which we really hope is just community engagement in the terminology development process so we can make sure that we get it right. Next slide, please. Announcements. Next slide. Oh, it's Mark. Hi, Mark. So many friends. We just wanted to ground everybody. So again, in the name of leveraging our relationship with HL7 as an HL7 Fire Accelerator project, you'll see that our communication strategy and our calendar approach has changed a little bit. This is really because HL7 has resources that as an accelerator, we have the right to use, and it's very easy and efficient for us to use them. So our email is now gravityproject@hl7.org. This will not change. It's who we are. And if you send us an email, it get routed accordingly to any of our different work streams, whether it be terminology tech or pilots. It also is the home of the conference call calendar. In the past, we had a send you an invite to the recurring meeting. There were some hazards in that, is like legacy invites, I think, are still on my calendar from a very, very long time ago. The conference call calendar is now self-service via HL7. You can just go to the HL7 calendar, then add it to your calendar. Or you can make an ad hoc calendar invite for yourself and just include the Zoom, but just know that's the big difference. So we won't be sending you an invite. You will need to access it. Our amazing Sarah Bahal, part of our team, has sent the introductory email about how to do that. If you need any guidance about any of this, you can find the information on our Confluence. You also can send us an email at gravityproject@hl7.org, and we'll just make sure that we connect you. Again, this is just, leveraging the amazing resources that HL7 has to just help us in our mission. Any comment there, Vanessa? Anything else you want to say?
I'll just add a quick hello. So I'm Vanessa Candelora. I know some of you, but not all of you, and hope to get to know all of you throughout your amazing work on the Gravity Project. Me being the newbie to the team, but I am the program manager of Gravity, having started in January and more officially in April. And as Sarah just described. Part of what we are working to do is to leverage some of the tools and resources through the partnership with HL7 that's Gravity has had since 2019. And some of that means that it might not be the way it used to be. And this was one area of those things. So the conference call calendar is self-service. I know for me, if I don't have it on my calendar, it's really hard to remember to show up. So please take the time for a few minutes to go out to that calendar and get it onto your own calendar if that's how you operate. And I'll just add that one of the big catalysts for that change is this community has grown so much. There are close to, I think, 2,500 people that continue to sign up. So you're going to see a few more changes into how we communicate to make it more self-service and to streamline as we continue to grow, so we have a more sustainable operational model for this this project that we want to keep going. And by the way, we're open for sponsors if anyone's interested. So with that, I'll turn it back to you, Dr. DeSoe. Thank you.
Vanessa?
Yes, Lucy.
Yes, I don't see a raise hand here, so I'm sorry to interrupt, but I wanted to ask you about getting into this HL7 calendar business. Does one have to be a member of HL7 to do that? And if so, is there a fee? I am not a member of HL7.
No fee. Don't need to be a member.
You can just
public calendar.
Yeah. Sarah Bahal, we can even, she put the direct link to the page. Sarah's amazing in the chat. And if you look on today, there's 12 meetings today on the HL7 calendar. If you click on the 12 on the calendar, then it takes you right to Gravity and you can add it. And if you need help walking through it, Lucy, anybody, this is literally like the domain of all domains to ensure we have no barriers to attendance. So if you need any help with that, just let us know, friend. We're here for you, okay?
I'd recommend one thing, which is there's a filter on that calendar page and you can filter to Gravity, and then you'll only see the Gravity calls across all our work streams on the calendar, which will help filter out some of those other calls that may not be interesting for you.
So will this link reproduce if I highlight it and go here later? This is a preference in Zoom. Many links that go into chat do not, in fact, copy and paste. So I just want to be sure that the preference when you put links in the chat are copyable. Is that true?
They should be, yes. And then,
okay.
And then again, if anybody has any barriers, email us at gravityproject@hl7.org and we will help you.
Thank you.
Personally, I promise to help anybody. Okay.
Yep.
No barriers. That's the mission. No barriers to entry. All right. Any other questions regarding this is really just administrative, simplifying, leveraging our resources from HL7. And then Sarah Bahal's like, literally, if anyone's going to be helpful, it's actually Sarah Bahal, not me. Let's be perfectly clear. So she's there we're all there to help. Okay. Our next announcement is regarding a refreshing of our strategic goals. Again, everything we're talking about right now can be found on the Confluence. We just try to leverage up the kind of salient things that are really important. We did have a refresh of our strategic goals recently, maintaining our data standard development for social risk, because we're here, right? Digital access and digital literacy. Here we are. Every 2 weeks, correct, Jonathan? That is absolutely correct. But we're also, having listened to our community-based organization partners and some of the outcomes of creating data standards for social risks, we are exploring standards to support eligibility and reimbursement and reporting, really with an eye to sustainable social care partnerships. What that means will become very clear whether you're here in this meeting discussing terminology, or in the implementation guide meetings on Wednesdays talking about use cases and new resources. where those conversations are, we will promise to help center you in those so you can maintain engagement in them. Again, this is terminology, so we'll mostly be talking about terms to support those things, but we promise to communicate to all of you via the listserv once you sign up to make sure that everyone can go and join where they need to go. New pilot partnership, if those of you don't know, so on the last Thursday of the month, you can find our pilot affinity group. This is through a direct partnership we have with Civitas Networks for Health with support of the Robert Wood Johnson Foundation. We have 4 new public health and health equity focused pilots. You can join next meeting. Our next meeting is a 5-hour session of the pilot affinity group leading right into the gravity call. So there'll be a lot of opportunity to engage in that work as well. And lastly, just again, we want to make sure everybody knows that there's some upcoming connect-a-thons. We have the July CMS HL7 connect-a-thon, which is virtual, July 18th to 20th. And then there's a link to engage in that right there. You can find that through the HL7 Confluence. And then to be determined is the sign up for the September HL7 working group meeting in Phoenix, Arizona. Again, all of those are available on the Gravity Confluence for further announcements. Thank you, Sarah, for the chat element. And the next slide, please. We wanted to have a brief update from our technical director. I don't know if Corey's on the call. He was en route from the working.
Yes, I'm here, Sarah.
Yay! Okay. Fantastic. So we used to have very extensive updates in technical workstream and policy here. We really want to make sure the voices that are engaged in the IG attend the meetings that are happening on Wednesday. But as a teaser, please come join us, our amazing technical director, Corey Smith. Do you want me to read this? Can you see it, friend?
No, I can do it. Can you hear me okay?
Yes, we can. Thank you.
All right, sure. Great. Good afternoon, everyone. So just a quick update. The key focus areas right now are on our fire implementation guide. We're doing what's called an STU update. We've heard a lot of feedback from folks that have looked at the guide, and the focus of the changes is on making the guide more readable, more implementable from a narrative perspective. And but what we're not doing is we're not changing with this update. We haven't made major changes to the actual exchange structure. So that's been a big focus of work, and we thank the MITRE team funded by CMS Obrey and helping us do that work. Also, as Sarah has already mentioned, a rapid design sprint is underway, also with the MITRE team, focused on determining eligibility for social care services. Sarah has already mentioned this bullet as well, across the Gravity project, doing some much more focused engagement work with our community-based organizations, social care provider.
I can no longer hear Corey.
Oh, I can?
Is this a standard problem?
No, I can hear him. I think I can hear him fine. So Corey, my apologies. I don't know what's happening with your connection, Brian,
I can hear him. Okay, I can't.
Sorry.
Okay. Sorry about that, Brian.
I'll try to figure out my problem.
Okay.
Okay, I'm almost done. So, I think at the end here, and this gets to some of Vanessa's points with our large community. There are many opportunities for engagement. We have reestablished public IG work group calls every other Wednesday. There is an open chat, a Zulip chat that's hosted on the fire site. That is a place where anyone can go and enter questions or comments about the IG. That is monitored by the entire HL7 community and members of the technical team. And there's also, if you have requests or feedback, there's also a tool called Jira within HL7 where change requests can also be submitted. Again, a lot of this is given the large size of our community, we're looking for self-service tools that don't require our small team to, we can't always respond to all the emails. And so having a community monitored chat is something we're looking for, as well as using the other community focused tools like Jira. So that's all. Thank you, Sarah.
Thank you, Corey. I also want to mention something you've mentioned before and Vanessa's mentioned. If you put in a Jira ticket, we're also accountable to it, right? So it develops a way of tracking and making sure that we're accountable to resolving that ticket. So it's a great way to make commentary that you want to have like logged, that is accountable and has a direct process. So again, anyone who wants to engage in the ID, we really encourage you to join those Wednesday 1 to 2 p.m. Eastern Standard Time meetings, and you can join the amazing Corey over there and the team at MITRE as we explore all kinds of interesting things regarding the ID. Next slide, please. We just wanted to mention also, anyone who's been here for a while know that as we grew, the Confluence grew as well. And as it grew, it might have required some pruning. It might have been, I'm an old farmer, as you know, it might have been gotten a little bit bushy and confusing to navigate. With our partnership with Civitas over the course of the last months, we've really done a deep dive into making the Confluence more efficient for users and simple to navigate. This includes really useful quick links, which include access to all of our value sets and deliverables, general gravity, like overview materials, a link to the website, a reference library and a resource library for implementers, really again, focused on implementers. I can attest to the amazing work that happened within the team I get to work with in terminology, which is instead of just talking about the value sets, making the OIDs within links to VSAC readily available. So there's a new terminology value set page where any implementer can go and find really, which is the outputs of this amazing collective in terminology. You can go right there and you get the hyperlink to the value set that you need for whatever one of our previous domains that we've worked on, each of those activities and those instruments. Just an incredible amount of work, a Herculean effort, and just incredibly grateful for that. So we're very honored and excited to offer that to you all as an update, hopefully making the Confluence more easy to use as a resource and easy to navigate, and actually improve engagement as well, because even finding this meeting or finding the IG meeting, we've tried to improve and make more simple. So please explore that and let us know how it's working for you, and because we hope it's working better and a little bit less cacophonous than it was before. Next slide, please. And then lastly, we want to do a community announcement with a sister project for the CDC. We do try to elevate things that are related to our work here. So this is the CDC webinar that's happening tomorrow at 10 a.m. Eastern Standard Time. It's within their data modernization and social determinants of health series, and it's the role of social needs data. They're going to be sharing findings from their STOH Data Exchange for Chronic Disease Prevention Initiative and discussing how social needs data collected in the healthcare delivery system could be used to remove barriers to healthcare and healthy behaviors. If you remember, we collaborated a while ago on the CDC public health use cases. Those use cases can be found on our Confluence as part of our sister work. So we're happy to elevate that webinar and invite you all to attend, and you will find many Gravity friends in that meeting as well. All right, next slide, please. And then we're just gonna do a quick overview, because even though you can tell by my reaction, there's many old friends in the meeting, we don't want to make the assumption that there are no new people. So we're going to do a quick grounding, because this is the restarting and the kickstarting of the terminology public work stream. So we just want to make sure everyone understands. And you're also going to be getting a chance to see some of those new overview slides that you'll find in the quick links on the new Confluence when you go there, in case you want to disseminate and share information. So the Gravity Project is a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. This is your PMO, the tiny mighty team. This is me. I'm the director of terminology, and I assist leading the pilot work stream. Corey, in kind from the AMA, is the Gravity Project technical director. And then there's the amazing Vanessa Candelora, who you just met, who's the Gravity Project program manager. Next slide. Again, just as a grounding, many of you all seen this slide before, but when we work in this space, we work with a grounded definition of health equity, which is the state in which everyone has fair and just opportunity to attain their highest level of health. We discuss social determinants of health carefully at a community level, and I'm just going to say that very, very plainly. They're the conditions which people are born, grow, live, work, and age, which are shaped by the distribution of money, power, and resources. And you can see the brackets for anyone who's been on this journey with us. We're being very careful to talk about STOH at population and structural levels. Social determinants of health can offer both positive and negative forces. For past friends, those protective forces are the characteristics or strengths of individuals, families, communities, or societies. that act to mitigate risk and promote positive well-being and healthy development. And then the negative forces are social risks and social needs. Social risks are the adverse social conditions associated with poor health, and social needs are patient-prioritized social risks. And someone very kindly noted that I'm talking fast. I'll try to slow down, but yes, these elements are recorded. I mean, the whole meeting is recorded and can be found on the Confluence for later review, but I'm going to try to slow down. Perhaps I'm a little bit excited to be back with you all, but I'll try to slow the Sarah train down a little bit to make sure that I'm not missing anybody.
Sarah, you need quotes at the end of shaped by distribution of money, power, and resources. I assume you're quoting
Thank you,
from somewhere.
Lucy.
Thank
Thank
you.
you.
Okay, bye.
Thank you so much. Next slide, please. This is from a picture of the Health and Human Services strategic approach to addressing social determinants of health to advance health equity. That middle stream is coordination across sectors to promote health equity and achieve holistic care. Where we see gravity landing is in data standards related to support that Health and Human Services integration. So this is where we fit in the general approach to addressing social determinants of health to advance health equity within the national ecosystem. Next slide, please. Our 3 use cases that we use in our work at BASE are documenting social care data at patient and client encounters, tracking social care interventions to completion. And you can see these are person level activities. Again, it's kind of the inverse of the social determinants of health and social risk and social needs terms we used before. Again, those social risks and social needs are person level terms. Social determinants of health are macro community level terms. The last use case is gathering and aggregating social care data for uses beyond the point of care. This is for purposes of population health, quality reporting, risk stratification, research, policies to foster health equity. The reason why we note that this is important because one of the frameworks that we work from is the World Health Organization Conceptual Framework for Action on the Social Determinants of Health, which really stresses that as an ecosystem, we have a responsibility for creating structural level solutions, even as we address person level problems. The data that's found in gathering and aggregating social care data really are the arrows and the kind of the lighthouses to direct where those structural solutions need to be addressed. Next slide, please. These are our principles. We worked really hard on those over the course of our first couple of years. Again, Gravity works to address what we call the injustice of invisibility from a data justice framework. There are things we could not name, things we could not say. There was no term for transportation insecurity and claims. Many of the interventions that we use to address social risks, we didn't have any terms for within health information terminology, but we recognize the risk of being made visible. So we have these six primary principles we use when we apply our work. These are improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and preventing, reducing, and remediating harm. Next slide, please. These are our amazing sponsors.
Sarah?
Yeah.
Sarah, I'm sorry, who does ensuring personal control refer to? Personal control by who?
The person, the patient, the client.
The patient.
Yes. Do you remember we made those together, Lucy?
Yes, I do remember, and it's very rare to see that implemented. So I'm glad to see it still in the principles, and I hope we all keep our eyes on it because personal control is declining, in my humble opinion, and we'll see how that goes in the next few months and years. Thanks.
Thank you, Lucy. Lucy's a very amazing patient advocate in our space and in our community, and we always thank you for holding us accountable to the things we say. So I hope you do make sure that we remain accountable to it. We define it as a principle with just that concern in mind together. So these are our 2023 project members, sponsors, and partners. Again, very, very grateful. We are a member, a sponsor-driven organization. These are all the folks that have leaned in for 2023. As Vanessa noted, if anyone wants their organization to become a sponsor, please reach out to us. As you all know, Gravity functions sponsor dependent, and so we're back with you because of the strength of our sponsorship model so far, but we definitely, for sustainability, will have a little bit of work to do. So we hope that any individuals interested in sponsorship will reach out and support us. As you can see, stars are with people who've been with us from the beginning. Next slide, please. Oh, and I just want to note before we move on, sorry, there are some individuals that offer such significant in-kind work that they're both a sponsor and in-kind, or they're just in-kind. These are individuals like the American Medical Association, which in addition to being a sponsor, offer an incredible amount of in-kind support. Civitas Network for Health leaning in with the pilot work stream, and then Saffron Labs across tech and leadership. So incredibly grateful to those individuals. Not AMA is both, but a significant investment in the resources and work of our project from those three organizations. Next slide, please. This is you and all of you. So Gravity convenes over 2,000 participants from across the health and human services ecosystem to develop and test social determinants of health data standards. The stakeholder types across the vast collective are many. So we are everything that we've over the course one can imagine across the social care ecosystem. So we're very, very grateful for all of your representation. Next slide. And next slide. So this is our exciting roadmap for 2023. In terminology, you can see here we are leaning into, this is where the dotted line is where we are. Our build focus right now is digital access and digital literacy, and we've convened subject matter experts to assist us in that work. We do have a few proposed areas of work. These include expanding terms within material hardship in order to make sure we have the granularity to address patient care, expanding terms within transportation insecurity to ensure that we have different subtypes, including specifying more clearly when transportation insecurity affects healthcare access. And then we also, in line with our exploring reimbursement and CBO support, are considering proposing and considering expansion of food insecurity terminology value sets with a coding for food initiative that would allow community-based organizations to report on food products delivered in line with many different regulatory drivers that are in the ecosystem right now, whether it be state-based regulation or Medicaid policy. Again, this is a to be determined project, but these are things that we have in our roadmap. You might be seeing these as we go on. That's why they're proposed, but they're all things basically that we could turn on once we have the consensus that we need to. Over in tech, you have, again, that update for STU2 that Corey was speaking about. You have that rapid development of the eligibility for social care services led by MITRE. You have the Connectathon we just finished, heading into the CMS Connectathon in July. We have our focus on integrating community-based organization and social care organization feedback into the IG and really into our model as well. And then you have in pilots our support for our previous pilots in phase 1, which you can again find the last Thursday of the month from 2:30 to 4. And then our new public health and health equity focused pilots. So we're doing all of that at the same time, all while improving education and dissemination for implementers. So although this is the first meeting for this work stream and a little bit in a public setting, we have been very busy. And we are very excited to come back to you. So you can find the direct work of the IG in those Wednesday 1 to 2 EST calls. You can find terminology here every other Thursday from 4 to 5:30 Eastern Standard Time. And you can find pilots on the last Thursday of the month from 2:30 to 4. All those meetings will be at the end, but all of this is happening. And we promise to try to connect you as best we can. Thank you. Hi, Janice. All right. Any questions?
Hi. Sorry, I'm late.
Oh, it's lovely to have you here, friend. Any other questions before we get into our specific terminology work? Again, this was updates, overview just to ground everybody, roadmap just so you all can see all the different things that we're doing across our 3 work streams. And now we're going to dive into terminology. We good? All right. Next slide, please. And next slide, I already did questions. All right, this is the terminology work stream. This is the terminology team. So Gravity Project Terminology Team, this is us. This is myself, again, terminology director and work stream lead. We have Molly Satewall, who is Terminology Clinical Informatics Lead. We have the amazing Monique Van Berkram from AMA, who comes in as an expert across terminology and tech. We have Asha Manuel, who's a population health expert, community liaison, and informaticist. And we have Sarah Bahal, who's a project coordinator and terminology analyst. And this is the core of the team that are always working to make sure that we carefully construct the elements that that the collective defines, that we leverage the expertise of the subject matter experts, that we build it all into terminology, and we curate it in value set. So this is all the core team that has been working on this work for some time. Next slide, please. I have the honor, she's even here with us today. So we made this special slide for our dear friend, Linda Hyde. Don't be too embarrassed, Linda. Her nickname as she went into retirement was the Dowager Queen, because dear Linda was the heart of our terminology work stream for a very, very long time. She was our lead terminologist for our first years of work. She postponed retirement at least 3 times to ensure we were on steady ground before she left. We miss her greatly and are grateful for her company and all the methods and practices she helped us establish. And we just wanted to give her her moment in the sun. We adore you, Linda. We miss you. And we hope to keep making you proud. And we hope that you're enjoying retirement finally. Just many, many thanks for all the work that you did over the course of the years. And just know that you're very appreciated. And we hope your gardens are lovely. Next slide, please. This is the scope of the terminology workstream. This is what we do. So over in terminology, our job is to develop data standards to represent and exchange patient-level social risk documented across 4 clinical activities. These are activities of screening, uses standardized validated instruments encoded in LOINC, the activity of assessment and diagnoses using ICD-10 terms and SNOMED CT terms, the activities of patient-centered goal setting, currently using SNOMED CT, but we also imagine futures where we could use LOINC, and the activities of intervention using a breadth of SNOMED CT terms across a structure that we crafted in our early years. We then test and validate those standardized social risk data for use across all of our different use cases. We've covered 17 domains so far. We're about to cover 2 more. Again, I want to note that some of those things you saw in the exploratory work will be new activities here, or at least a refinement of some of those activities. So for instance, if we need to build HCPCS terminology support reimbursement, it would be a subtype of intervention. We do have some HCPCS terms already, but it would be a refinement of that previous work.
Sarah?
Yes?
Would it be in order to begin to consider a 4th bullet called completion? You have screening, assessment, goal, intervention. Is there a need for how to address completion?
That is an interesting question. And I wonder whether you're talking about a term for it or a resource for it within the IG, like how we can think about completion of tasks and things like that. And what is your thought regarding the why? I can imagine a million whys why that's important, but where are you coming from, Lucy?
There was a previous slide that talked about completion. So I'm just wondering, as a clinician, you can do screening, assessment, goal setting, and treatment. Do you have to report or notify anybody when, for a particular patient and that problem, completion has occurred? Would that be in the IG, or is that something?
It's in the IG and not. So I think about those things as statuses of terms as opposed to a specific term itself, but I really love that idea.
Okay.
Wouldn't you complete each one of these though, right? So the intervention and treatment you would complete, right? Your goal setting you would complete. So each step would be completed as a status.
No, I mean the episode. Let's call it an episode. Somebody comes in and during screening, they report that they missed a meal in the last week or whatever the screening tool asks. So I'm thinking of completion of the episode when this individual reports not having enough food. Like the next time you see them and ask that same question, the answer would be different.
Yes, and so someone's raising this, so I help welcome Maddie. Intervention treatment delivered does not necessarily mean the underlying need was met or the situation is resolved. That's partly what why we built our goal statements, right? So the patient has the option, we center the patient in determining what met means for them, right? And we certainly, I'm just going to state this out loud, even though it's a bit of a sticky wicket. Some of what you're talking about, Lucy, we've explored when we consider a use case that we have yet to really dive into yet, which is outcomes, right? So in our early work, you probably remember this. We started to talk about.
Okay.
Yes.
Yeah. What is
Yeah,
what is the outcome of this episode? I guess that's what I'm struggling to articulate here, and whether we need to account for that in a formal way. Yes.
Yes. Yeah. So I think there's space to revisit that, and I hear what you're saying, right? So, and there's been a lot of conversation regarding outcomes within both terminology and tech. Terminology for outcomes, like what we want to say an outcome, like what we want to define an outcome as, whether it's a terminology definition, whether it's a terminology statement or a technical statement or a status statement. And I can really imagine having those conversations with you all. And again, these were our initial 4 activities. There's a lot more going on now. So whether
that's why I raised it.
Yeah, I know. Smart,
okay.
Lucy. Great. So maybe let's just hold space for the fact that outcomes are something we're trying to figure out an approach to, and not just in gravity, but in general. I mean, even ONC, right? We're collectively trying to figure out what we mean when we say an outcome. It's something we've thought about a lot within gravity, but yes, I can totally imagine how outcomes might be here, or even in our original, in addition to our use cases, or otherwise explored and way to bring back that thread, Lucy. Oh, hi, Mike. Yes, of course, Mike Klinkman's coming in with his wisdom. Yes, and yes, Vanessa, right. So perfect. Thank you, Lucy. And just note that this has not changed. It likely needs to be updated, and this is why this group is so amazing. Thank you so much for your wisdom. Any other thoughts on that before we move on? Great. And then we are again convening a lot of really brilliant voices to help us understand concepts regarding community-based organization engagement this summer. Maybe it's just something we can help explore through that as well. Just know we hear you, and if there's a kind of a thought cloud we've been having as a collective about how to address that, but it'd be wonderful to have that conversation here. Okay, next slide. Yes, so John, I just want to note that depending on how we've defined outcomes, there's been a million different ways we've conceptualized it, whether it's be the resolution of a need as identified by a change in a screening instrument, whether it be a goal met, whether it be, so there's all kinds of elements of temporality when we start talking about outcomes. So I don't want to say that we've thought about all of them, but we've definitely explored a lot. And we look forward to having those conversations with you all further. And correct, yeah, so there's a lot of the care plan model that we're leveraging, Cheryl, when we talk about what outcomes might be. We do have, again, that's why I mentioned those goal statements, because certainly in care planning in my daily practice in family practice, I use patient-centered goal statements and attainment to goals as the outcome that's a primary concern for the patient within care planning. But we would love to have, this is a really great place to bring those conversations, to have them further. And we look forward to that, right? We can do that over the course of the next months. This is, after all of that exciting conversation, this is a very tangible, concrete example of what we create, right? So based on those 4 initial activities, these are 4 types of data that we've created in the past in this group. Encoded screening instruments that are assessed as face valid, encoded specific diagnoses for social risks, encoded goal statements, including there's that food security as a goal, or a critical we call midway goals. So food security might be the meta goal, but right now a patient might just want to feel the food intake quantity is adequate, right? Not the pie in the sky. I just don't want to feel hungry, right? And then we also have all of those procedure terms that we work on, which are really the encoding of all the core federal programs and really critical internet, like universal national programs and the pathways to them. So the referrals to them, the provision of the thing, education about it, right? So that is all of the output of our intervention elements. So each of these different 4 types become part of those value sets you can find on the Confluence update. And this is all from you, right? This is all work that we did in our kickoff year in 2019. This has now been replicated across the 17 additional domains, and we're about to do it for digital access and digital literacy as well. Next slide, please. All right, and now I get to pass the mic to the amazing Hamali, who's going to update on some gaps that have been filled and some terminology updates before we dive into the specific kickoff for digital access and digital literacy. This used to be called Linda's Corner. It's now Hamali's Corner. Next slide, please. All right, you want to go, Hamali?
Yes, thanks, Sarah. So Sarah has touched base about this slide previously. So this basically is the slide that provides an overview of the value sets which are built for Gravity 17 clinical domains across 4 activities, and those are hosted in NLM's VSAC tool. There is a link for the VSAC, and if you are looking for the individual value sets, those are also referenced in on the Confluence page, Gravity Confluence page. Next slide, please. So this provides an overview of ICD-10 CM April 2023 release codes that we have worked for past year or 2 and finally got released into the April 2023 version, around 25 plus codes which has been released in this version, and these all codes we are in process of updating existing value sets to include all these codes for related clinical domains. Next slide, please. So for Synomed CT and LOINC, we are again working. We were not in light for last 1 year when it comes to working on new domain, but as Sarah mentioned, we have been immensely working on updating the terminology and adding it into Synomed CT and working very closely with Synomed CT US and international people as well as LOINC staff to get new codes added into Synomed CT. And these slides provide a list of codes which were not for the clinical domains and activities which were not available at all in the ecosystem, but with the work that we have done together with you guys and with your inputs. Now for health insurance coverage status diagnosis, there is a code added to Synomed CT, which is no health insurance coverage. And for ICD-10, the code is encounter for counseling for socioeconomic factor. For veteran status goal, there were no codes available in Synomed CT, but now we can see honorable discharge for military service and eligible for veteran affairs benefits in Synomed CT. Next slide, please. So the slide prior shows the codes which are released and available for the domains where there were absolutely no codes. But apart from that, all the 17 clinical domains and 4 activities were lacking multiple codes. And with March 2023 Synomed CT release version, Gravity was able to add 229 new codes for Synomed CT US and 33 new codes for Synomed CT International, which is, I think, a huge accomplishment. Through Gravity, we have an opportunity to build social care terminology infrastructure for US and international versions. So thank you to all of you for your support in building the social care ecosystem infrastructure for US. And we are also working with LOINC, and till date, in past 1 year, we were able to submit all these screeners to LOINC, and American Community Survey and Perceived Stress Scale is recent submission, but all other submissions has already been in process for LOINC, and we are hoping that in 2.75 we will be able to see all these screeners in LOINC that then we can use for coding. So this is another great accomplishment.
Huge.
Next slide, please. Yeah. I think
Could you,
with that. Yes,
could
Lisa?
you, could you comment on these LOINC submissions? Do all of these items, do they duplicate? Are they complementary? Is there value added by all of them, or only some? Or could you talk a little bit more about all of these different? Thank
Sure.
you.
So basically, all these screeners which we identified through gravity process are either federally recognized or most commonly used screeners in the clinical practices. And all these are currently used as a PDF version or in a way, non-standardized way to screen patient. And it would be extremely helpful if we have a standardized version of these in LOINC. So these are not available in LOINC, but we worked with the individual screener point of contact authorities, got their permission to include this into LOINC. Then we worked with the Region Strip Institute, got the permission satisfied from their end, especially American Community Survey, which is sponsored by US Census Bureau. I think it took us 6 to 8 months just to get an agreement between US Census and Region Strip that we submit that. So it usually takes 6 months to 8 months of period to sum up those screeners to just pass that initial hurdle. And then we work with Region Strip to put that submission into a queue. And once that stage is achieved, it is usually 6 months of time period from the submission till it comes into LOINC. Sometime it is 1 year as well. But none of these are currently available in LOINC, but we have submitted it, and we are hoping that those codes will be available for community to use.
Thank you for those details. I appreciate it.
Absolutely.
Just to
And
reiterate,
great work. Really,
Yeah.
this is the kind of root level detail that eventually yields uniform reporting, helpful for absolutely everything. Thanks.
Thank you, Lucy. I'm just going to hold up something Hamali said, like we don't intend to encode every instrument because that would be way outside of our scope, but we lean heavily into the most commonly nationally implemented validated instruments and any federal tool that's utilized across both clinical and public health ecosystems. Right, so that's primarily our charter is we say what are the most important gold standard tools or validated short tools, right? And then what are the questions that are repeated across different federal implementations, because the questions from the ACS are repeated over and over and again in multiple research studies for public health and clinical applications. So that's our approach. So each of these really fill critical gaps, and we're very grateful for the patience of the ecosystem, and I'm grateful for the patience of the team. It's a lot of labor, and yes, you're right. So this is the path to our charter is to craft data standards for these things, and this is a fundamental building block.
Thanks.
All right.
I think I will pass it to you.
Yeah, so we're off to the races now. Next slide. I can't believe it's already been an hour and we haven't even, there's been a lot of updates. Next slide, please. Okay, oh, sorry, if we go back one slide. This is a very silly little visual that I made, but it really helps talk about the life cycle of our terminology development. All the pre-work is what is behind the scenes. It's Asha and I identifying subject matter experts. It's all the outreach. It's the vast curation of literature. It's analysis of different coding browsers. It's all of the work that we lean into. We say what terms are out there, what is the literature, what are the instruments, who are the experts, get ourselves ready. Again, we are an evidence-based work stream. All that gets curated in the back. And then we do this together where we identify what we need. Independent, but also connected to what's already exists. And then we collectively review it as a team to make sure that we feel like it's fit. We have a consensus vote. And then the team analyzes gaps between what we need and want and what exists. We work with our standard development organizations to build those, including building value sets. And then we evaluate and test. So part of what we're doing in the pilot work stream and with anybody who will help us is testing our hypotheses, like, did we get it right? Are our goal terms helpful? Are our intervention team terms complete, right? So this is the life cycle of what we do within our work, and we're in the identify stage right now. Next slide. This applies to a schedule driven by, it's all formulaic for those of you who've been here before. So we have a kickoff. We have 3 concept meetings where we really kind of like drum up the things we need to say. Then we collectively sit back and analyze what we created, do an end-to-end review, make sure that it's complete. Are there things that are wrong? Are there things that are missing, right? Are there things that we need to edit? We do that twice, and then we have a vote. And then that's in August, and then the build starts, right? So then the terminology team behind the scenes starts working those standard organizations to prepare submissions, collaborate, submit, so that we can get to those final terms. So next time when we come back, you'll see in our homework is to start submitting instruments, submitting programs, start getting ideas for missing terms so we can build them into our sets. And again, the cadence is every other week. Next slide, please. Oh, that's nice. I know the old Sarah Hall calendar. Here we are. Okay, we have a half hour to get into the digital literacy and digital access kickoff. We have a few of our experts with us. I saw Walter enter. I saw Adriana here. I don't know. I think I saw Boomi arrive, but I'm going to take lead only because of the time frame. But as always, please interrupt me. I am not a subject matter expert in this. I am a helper. So anybody who has nuance, and there will be plenty of people who have nuance, please let me know, and you can chime in again, and you'll meet the subject matter experts shortly. Next slide. These are amazing subject matter experts. I just so grateful. We have Walter Suarez, who's well known to this ecosystem, who's the executive director of HIT strategy and policy at Kaiser Permanente. Adriana Nava from NCQA, who's a research scientist. I work with Adriana across a million different projects. So excited to leverage her wisdom here. Professor Adriana Aguilera, who's a professor from UC Berkeley, who's the director of the Health Equity and Access Lab. Boomi Kamajola, she's a project director at Wisconsin Health Literacy. And then we have Jorge Rodriguez, who's a clinical investigator at Brigham and Women's. And I might have mispronounced Boomi's last name, and I'm so sorry if I did. If Boomi, if you can correct me if I got it wrong this time. I think I got it right on Tuesday, but I got it wrong today. But these are our 5 subject matter experts for this work. They already are proving brilliant in helping us make sure our slides are correct. We will be grateful to leverage their insight and wisdom as we go forward. Next slide, please. Just again, some definitions to ground us. All of our definitions are in process. These are existing definitions that we will then collectively make sure are fit for our use cases. The thing that's interesting here, which is a new concept, the digital literacy and digital access in some settings, including SAMHSA, are described as super determinants of health because they influence almost every other social risk. So whether if you have poor digital access, it influences your ability to sign up for it, like electronically for food stamps. If you have poor digital literacy or low digital literacy, it influences your ability to have healthcare access, right? So it's termed, whether it be from SAMHSA or World Health Organization or other entities, as kinds of super determinants of health because of their capacity to influence everything else. And again, chime in any brilliant subject matter experts at any time. Digital literacy, again, the definition in process, this one's pulled from the American Library Association, is the ability to use information and communication technologies to find, evaluate, create, and communicate information. It requires both cognitive and technical skills. And then digital access is in process, is access to high-speed internet and broadband access and access to a tool to use it. I think I have a typo there. So it's not just the existence of reliable high-speed internet. You have to have a tool to use it. Hi from rural primary care on the Canadian border. This is my daily life, especially within the last 3 years of telehealth and the COVID pandemic. Addressing this as a barrier is something I address every day. Next slide, please.
Sarah, you won't be able to answer this question, but with the elimination of the public health emergency for COVID, is that going to affect, it may or may not affect telehealth, but I'm really asking whether it's going to affect digital access. Have people been enabled to have digital access because of the public health emergency? And if so, will they lose it now? Maybe someone on the call knows that.
Maybe someone on the call does that. Feel free to type that answer into the chat if you do know the answer. I do know that some of the ending of some of the loosening of regulatory requirements regarding telehealth that were proposed, especially the regulatory requirement about prescribing controlled substances and telehealth only visits. The public comment on the sunset of that rule was so robust that the administration is pausing on that. So I feel like what I am understanding as someone who leverages telehealth extensively to address transportation insecurity in rural family medicine is a lot of the perceived to be temporary extensions are being extended because they are addressing inequities. More granularity can come from that from somebody who knows policy better than I, but the direct example of that is the attempt to sunset or change or alter the requirements regarding telehealth prescribing and controlled substances, and the extensive public comment regarding that and the pausing of that. Was that
Sarah? This is Walter. Can I?
Yes. Come. You want to answer that question?
Yeah. There are over 100. Yeah, about that question. Yeah, there are over 100 programs from more than 15 federal agencies supporting digital access, digital even literacy for that matter, and as well as telehealth services. So I think, and then there are some legislation and some regulatory action that have been taken by agencies to telehealth services
Walter,
the health emergency beyond emergencies. So that, I think we are safe to think or to see that that's going to continue.
Walter, your audio cut out a little bit. But thank you for the answer, and thank you, Mark. Maybe Lucy will explore that as we go forward together over the course of our work. Does that sound like a good approach? And thank you, Mark, for his always wise policy answers. I just want to note, I'm going to continue. Any other questions on or elements regarding Lucy's question and Walter's answer and Mark's comments in the chat? Okay, I'm going to keep on going then. I just want to ground us, because for those of us who were here in previous years, I just want to note patterns. Digital literacy was pulled from our work in health literacy last year as a unique aspect and area of concern. I just want to note again, just like we did with health literacy, we will again consider both personal and organizational sources, right? So there's organizational health literacy and personal health literacy. There are personal and organizational responses to digital literacy, making things more accessible, right? So not all the responsibility or interventions in this space are on the person's responsibility. We address this extensively in health literacy, talking about organizational responsibilities and personal level responsibilities. And those themes, you're going to see them again, right? We also will need to consider the different aspects and skills within digital literacy. You'll see that very shortly. Again, this very closely mirrors health literacy. We talked about numeracy. We talked about all the different subfacets. And for most of the aspects or skills within digital literacy and health literacy, there might be different instruments that address different subtypes. This is work what's well known to us. We explored it with health literacy. We did very similar work in social connection. Again, considering how questions are aligned with subdomains and there's aspects and skills in order to make sure that we're coupling the right questions and answers. Thank you so much, Amy. Digital access is pulled from our work on material hardship as a unique concern, and we'll need to again consider environment, like it's not present. and financial resources. I cannot afford it. Again, we explored all of this with the material hardship. I want to note again that access, again, as noted before, is not just the broadband access, but it's also the presence of the tool. And I think this is what Mark was highlighting before, that there was also this element of without special effort, right? So we've talked about elements of that before, like what adequate or like, you know, burdensome, right? That was all very clearly expressed within our material hardship work about what level of effort to access things is expected or okay, and what level of access is just beyond the pall and beyond the, I'm forgetting my statement here, but just is not to be expected and is a barrier and inequity. We would have to address it. I just want to make so that I just ground us here, because again, you'll see these themes pulled forward. We've done work very similar to this, and again, in health literacy and material hardship and even social connection. So you'll see those themes as we go forward. If you want to review the past materials from those other domains, feel free to, just to see how we approach those things before. Next slide, please. Next slide. This is a slide that I actually made for a different group, but it's applicable here. So one of the things that we wanted to just ground ourselves, this helps us understand those aspects, elements. So there are dimensions of social insecurities that are common: food insecurity, housing, transportation, and digital access is one of those. Those dimensions are worry, stability, quantity, quality, or safety, and cultural acceptability. You can remember those elements being really critical and centered in the gold standard USDA food security module, which addresses everything but cultural acceptability. And again, you can see those themes would be appropriate here again within digital access, where you have stability, quantity, and quality, right? All being really critical aspects that we need to make sure that we're considering as we're building out these terms. And then where digital definitions related to digital inclusion consulted. Well, we will consult them together. So thank you so much for adding this, Amy. Right. So certainly my guess is our subject matter experts are well aware of that, and we are just beginning our work. So we will ensure that we center that as we go forward. And then I just want to add the cultural acceptability is both, is not really applicable here within access. It might, even though it might be, and maybe this is what relates to Mark's question, but definitely is related to digital literacy. Does it make sense? So again, each of these different subdomains, these dimensions of the concern are important when we think about economic driven inequities and insecurities, whether it be food, transportation, housing, and we've talked about these things in the past. Next slide, please. One of the things that we do when we do our work too in a kickoff, this is a kickoff, is talk about the why. There's a lot of literature, and again, subject matter experts come in and help me if you feel like you want to, regarding the digital divide. There's a lot of information from the FCC. AHIMA has a lot of publications on this in all of their expertise. Just some data: the least connected counties in the US have the highest rates of chronic disease, according to the FCC 2017 Mapping to Broadband Health in America. It was an amazing interactive map, which is just beautiful. In 2021, the rates of wired high-speed internet use were lower in households where the main renter or owner was 65 years or older, had a disability, or was Hispanic, African-American, American Indian, or Alaska Native individual. You can see clearly the inequities there. Households located in rural areas were also less likely to use high-speed internet. Broadband services are available for almost 98% of people living in urban areas, but just over 70% of people living in rural or tribal areas have broadband services available. And then even if broadband internet's available in a community, the cost can make it unaffordable for people with lower household incomes. And this is what I was relating before, that mirroring of material hardship. It might exist, but I cannot afford it, or it doesn't exist at all, right? So while over 8 in 10 households with incomes above 100,000 use wired high-speed internet service at home, only about 5 in 10 households with incomes below 2,500 did in 2021. Correct, and we will want to track both wired and wireless access and divides. Correct, Mark, thank you. Yes, wonderful. Thank you, Amy. So much wisdom there. And then we just want to note that all of this is, of course, mediated by not having a device to access whatever is there, right? So if you do not have a device to access internet, it doesn't matter if it's there at all. And Amy, thank you for that wise statement. The geographic clustering of digital exclusion with SDOH create the equity problem. Wise and noted. All right, next slide, please. This is a brief update on digital literacy, and then we can open up for a little bit of homework and conversation before we go forward, because this is just to ground us, and then we all have work to do. Next slide, please. These are just some core literacy aspects and skills. And Adriana, if you want to weigh in, that's great, or Gloomy or Walter. So these are just some of the elements we were discussing. So just like with health literacy, there's just an aspect or skills that relate to comprehensive digital literacy. These include essential computer skills, or the skills needed to control digital devices and use them to accomplish tasks. Network literacy, which are the skills required to access and curate information as required by social networks. Digital problem solving, which is the ability to navigate and use multiple digital resources to accomplish goals across domains, including work, personal interests, educational pursuits, social and professional networking, civic participation, and for future uses not conceptualized. Civic participation, professional networking, educational pursuits, you start to see how these elements relate to some information of inequities on the next slide. Information literacy is using technology to enhance information. Media literacy is finding, evaluating, using, and communicating information via the range of media. Social responsibility is using digital technology in a responsible and ethical manner. And identity security, ever important, is the capacity to protect one's digital information from misuse with a focus on safety. A lot of these come from a U.S. Department of Ed issue brief. What does it mean to have digital literacy skills? Just as a note, whenever we're building our terms with terminology standards organizations, using either comprehensive resources, gold standard resources, or federal resources are really important for making the case. And digital problem solving is not symmetric across all domains. This is complicated, Mike. It is complicated. It always is. But somehow we figured out over the course of our 6 months. The geographic clustering, I especially love when healthcare providers suggest having patients use the devices their kids got from school. Yeah, no kidding. Absolutely, Amy, thank you so much. Next slide, please. Oh, Ruth is here. This is just a different framework. Again, we're at the early stage. Nothing is defined. We're throwing things up here to set the stage of the work to come. This is work that came called the DigComp framework that came out of Europe, which really talks about different areas of digital literacy. So information and data literacy, communication and collaboration, digital content creation, safety and problem solving. Each of them have different subdomains. We just throw it all up here because we have to understand the ecosystem that we are working within, the C as we call it. And then we start selecting instruments for finding definitions and ensuring that we have interventions to address whatever social risks and social needs we've identified, right? So that is the process as we've done it in the past, and that's what we'll do collectively. The financial and health literacy in marginalized communities that needs to take place simultaneously. Yes, exactly, right? Exactly, Jonathan, thank you so much. The Venn diagram of needs as we talk about it, and it have talked about it in other situations and other meetings. Certainly, I know in my practice, none of these things occur independently or can be solved independently. Humans are complex, and inequities mirror that as well.
Sarah, could you repeat about this DigComp framework? Did you say this was from
Europe?
The common market? Does that mean that everybody in the common market providing healthcare and social services is using this framework?
No, this is just grounding materials to help us in our work. This is not saying that anyone's using this framework. This is the framework.
Okay.
These are, yeah, so as we begin our work together, it's important that we call to light any definitions, orientations, frameworks, models that can help everyone on the call understand the lay of the land. This is one that's in the ecosystem that we just put up here for reference. It mirrors nicely what was on the previous page. And
so could this be found now on the Confluence page? I'd like to study it. It's quite detailed.
Correct. Everything that is a resource here will soon be on the Confluence page. Yes, ma'am. On the page, like, so it'll be digital literacy resources at the bottom.
Thank you.
Yeah, everything we've cited, all of the different resources, and plus some that the subject matter experts sent us directly, that'll all be there very shortly. Oh, look, and Sarah Bahal found it on the internet and gave it to you in chat. All right, next slide, please. Important things when we consider digital literacy is health equity. And again, I'm pinch hitting for the amazing subject matter experts who just kicked off, which is the only reason why their voices are not here because they're on the call and we didn't want to throw them into the fire, but feel free to weigh in, friends. Populations particularly at risk are those with lower educational attainment, older adults over age 45, those not in the labor force, and those who do not use a computer at work. You can see how these things are interdependent and kind of, reinforcing each other. Low digital literacy is associated with barriers to education, educational attainment, and occupation, as you can imagine, in an increasingly digitized world. It's associated with barriers in access to information and resources, online information, portals, applications, et cetera. And within a healthcare setting specifically, even though that's not our only use case, is associated with barriers in healthcare access, raising that telehealth example there, and decreased patient engagement, including healthcare information access. Cultural competency lens is relevant to this domain, yes. You saw that as a highlight on the dimensions slide, where I called it out as part of the literacy element. Absolutely, just as cultural sensitivity and appropriateness was part of our health literacy domain, and we built specific both person level and organizational interventions to highlight that, understanding that those barriers are mostly the organization's job to solve. So we do have terms from health literacy that we can mirror as we do this work.
Sarah?
Yes.
I just want to introduce a hilarious reality, which is, as a patient, I sometimes find myself more literate than the provider, and I am barely literate. And so we should all recognize that when we talk about digital literacy, this actually applies to providers as much as to consumer patients.
That is a brilliant statement, Lucy. That makes a lot of sense.
Older providers are used to dictating and then seeing what they do written out by somebody else, and so they're not responsive. Okay, thanks.
I love that this early conversation is an example, both in the chat and those who are coming off have their mics on, of just the amazing conversation we're going to have. This is our kickoff and we're already diving right into it. I love this group so much. We just want to note that there's an opportunity for provider bias. Clinicians may select patients more likely to succeed using the portal, causing disparity populations and unequal digital access, along with many other things. Thank you, Madi. I hope I'm pronouncing your name right. Interesting podcast and health tech navigators agree patients and providers need them. Thank you. How appropriate. So what we've done, okay, next slide, please. Thank you. So we had just to level set on where we are, right? So this is our digital literacy and digital access kickoff. We had announcements to ground us. We did an overview to get everybody on board. We did terminology overview to talk about the process. We showed that lovely calendar that people were like, oh, it's the calendar, right? So then we grounded ourselves in the what and the why in this very nascent way, right? Initial definitions, initial approaches, understanding the C, right? Over the course of the next months, it's our job to define and refine our approach to our definitions, qualifying instruments, really important goal statements. Again, any of the barriers we're talking about, we should have goals and interventions to address them. So cultural competency is an issue of a note, and it is. We need to make sure we have the terms to name it and address it, right? So that's our work over the course of the next months. And there's homework regarding this. So now that we've done that, and we have the why, because we've talked about the literature, both in who's most at risk, right? And how it affects outcomes, both social outcomes and healthcare outcomes, right? Next slide, please. All right. So general, We want you to catch up as needed on materials. The Gravity Project Confluence still has every meeting we've ever had. The diagram you made is amazing after your name. We have him also, Lucy is also amazing. So if, for instance, specifically when it comes to the work of digital literacy relating to health literacy, it might be smart to look back at some of those build or identifying meetings, because that really will help shape our approach here. Those, again, all around the Confluence. So very soon, we're going to be creating a listserv specifically for this work stream, really because we're so big. Not everybody here wants to go to the tech calls, wants to go to the pilot calls. So you'll be able to curate information and curate where you want to be. There will be a specific terminology workstream listserv. Please stay tuned for that. And then regarding digital access and digital literacy, this is where we put you to work, right? We do our work here in this meeting, right? And you'll see very clearly how that plays out. You can tell there's some old timers on the meeting. We also do our work within regular meetings with our subject matter experts, where we leverage their expertise. We test things, hypotheses against them. We ask them to make assessments about whether it's valid and appropriate for the domain. But we also depend on you, right? All of you, not just in this meeting, but to help us make sure that everything we do is thorough. So we want you to submit by email to gravityproject@atel7.org screening instruments used to identify digital literacy and lack of internet access and lack of the tool, including lack of the tools. Sorry, I didn't update that. So, but digital access and digital literacy, if you have screening instruments that are crucial in your setting, we want to have them. They then will collectively assess whether they're face valid, right? That's part of what we do, evidence-based assessment of everything. We also want you to send us any critical programs used to intervene for both digital literacy and digital access. And we ask that you send us definitions and citations if possible. Again, everything that we do is evidence-based, incredibly nerdy, but if you have programs that are critical, we have a lot of from our old material hardship work, but we need to just make sure that we're thorough. And we also make sure that we encode and define and name the unique people, roles, and professions that are helpers in this space, right? There was no term for community health worker, believe it or not, before Gravity made it. So there are critical helpers in the ecosystem. We want to make sure that we hold them up. So if there are people, roles, and professions that are really critical helpers that you want to make sure that you center, please let us know. And that is the work that we hope you do before our next meeting. Before our next meeting, we will also be meeting with our subject matter experts and trying to get an initial, what we call master list for you to review, with some existing terms that have been assessed as valid at some instruments, some ideas regarding necessary diagnoses, et cetera. And so we'll get that to you, hopefully to review before the next meeting. And we'll go from there. Is that the same as computer literacy? It's inclusive of it, and I'm going to look to Walter or Adriana to answer that question, right? So I would say computer literacy is included in digital literacy, but maybe I'm wrong. Adriana or Walter? I'm going to put you on the spot.
That's correct.
I mean, I think it's included. It's inclusive. Yeah. Okay.
Great. I love that Walter's connection is not great as we're discussing digital access. Your audio is a little funny, friend. Thank you, Adriana and Walter, for coming in. All right, does everyone understand what we're doing here? Like what the task is? Read in anything you want to read. Wait for the list, an email with how to sign up for the listserv, and send things to us so that when we come back in 2 weeks, we can hit the ground running, right? Next slide. Yes, here we happily go again. I know. So engagement, right? There is more than this meeting. We wanted to level set and ground ourselves all collectively on where you can go within Gravity in order to engage in all of the amazing work we're doing. So we have 3 different public meetings. This meeting, Thursdays, 4 to 5:30 Eastern Standard Time, bi-weekly. The technical workstream meeting, which is Wednesdays. It's a new time, everybody. Wednesdays from 1 to 2 p.m. Eastern Standard Time. That's where we talk about the implementation guide. That's where a lot of the work that MITRE is helping head up will be occurring. An amazing group of really focusing on the IG. Then there's the pilot work stream. That's that monthly pilot affinity group meeting, which is the last Thursday of each month from 2:30 to 4 p.m. This is where we test our hypotheses, where we implement terms, we evaluate them, we support pilots in really broad mission-driven things like whole states implementing gravity terminology in order to address specific public health use cases. There's a lot of really exciting things happening in our pilot work stream in partnership with Civitas. You can find all of these again on the HL7 calendar. Vanessa gave you the tip to filter for gravity. Each of these meetings are on there. Please join us, right? The cast of characters in the team you can find in each of these meetings. We're all part of the work. And really hope that you engage in anything that you find to be interesting. And we just want to close out that we ask if you want to have your organization become a member as a Gravity Project sponsor. It's always appreciated. The work is important, and we're just very, very grateful for anyone who can help us do it. Oh, look, and Tim is coming in with a little FYI. Thank you, Tim. And then next slide, I think we're good. I think this is the end. We actually finished on time. We might have 5 minutes. We have a website, public website, which is public facing, kind of news, updates, press releases. The Confluence is where the magic happens, is where the labor of the work happens. And you can find all of it there, including our deliverables, value sets, the ID, etc. It's where you will eventually find this work. There are specific pages for digital access and digital literacy you can find there. And then just help us outreach. So if you feel like there's people that need to be here, come bring them to the group. If you want to share your experience here today, put it on social media, tag us, Gravity Project. At the Gravity Project is our handle, and we're very, very grateful that you're here. So excited to have the band back together. And we will see you in 2 weeks. Any other final comments or questions in our last 4 minutes? No?
Great, Sarah. Thanks so much.
It's so good to have you back. We missed you.
All of us.
Evelyn! Hi, Evelyn. All of our friends. We're so excited. We missed you so much. I've been verklempt all week, just knowing that I would see you. We look forward to seeing you in 2 weeks and continuing to work together. Bravo, friends. Have a good weekend.